Welcome to the second of our podcasts on vaccine hesitancy. My name is Tom Sorrell from Warwick University, and together with colleagues in the UK and Germany, I'm working on some philosophical issues raised by vaccine hesitancy. One of the questions we're interested in is whether people who are unwilling to take an approved COVID vaccine have good reasons to be unwilling. In order to answer this question, we need two things: research on why people are unwilling to take the vaccine, and a standard for calling some reasons good and other reasons less good or even bad. The standard is worked out by philosophers, but the reasons why people refuse to take a vaccine or hesitate about taking a vaccine are the topic of empirical social science research. Some of that research will be reported today by my guest, Mayuri Gogoi. She was a participant at an online workshop that the project held in June 2022 to review social science research into vaccine hesitancy. This podcast interview is a chance to follow up on some of the points she raised then. Links to the presentation can be found in the program notes. Hi Mayuri, may I begin by asking you to introduce yourself?
My name is Mayuri, and I am a research associate at the University of Leicester. I have a background in social work, and I did my master's as well as my PhD in social work. I did it from the University of Delhi in India. And my primary research interest is in migrant and ethnic health more broadly.
Can you please describe the research that we're going to be discussing?
The vaccine hesitancy work is part of the wider UK Reach project, which you may have heard of, and which was funded by the UKRI in August 2020, mainly to understand if and why ethnicity affects COVID 19 outcomes among healthcare workers. Because very early on, there was emerging evidence that there is a link between ethnicity and differential outcomes for COVID, with people from ethnic minority communities being more adversely affected. So this is what triggered, in a way, in a sense, triggered the project, and it was a big program of work that includes several sub studies or work packages, as we call these internally. And I was and still am involved with the qualitative sub study, which looked at healthcare workers' experiences of working during the pandemic. So we conducted individual interviews as well as focus groups with 164 healthcare workers. And these are from diverse roles, both clinical and non clinical, from different ethnicities, gender, even UK region. So we tried to bring in healthcare workers from the four devolved nations of the UK. And data was collected between December 2020 and July 2021. And healthcare workers was one of the priority groups to receive the vaccine.
Your study distinguishes between different kinds of active and passive vaccine acceptance and vaccine denial. Can you just explain a bit the differences between active and passive acceptance and active and passive denial?
The participants who we classified as active acceptance were those who had readily accepted the COVID vaccine and reported that they were, either vaccinated or willing to be vaccinated when they are offered the vaccine. So they had no ifs and buts about it. Um, the second category of passive acceptance, they often had one dose, or some even had both doses of the vaccine, but had concerns around its safety or efficacy. So they said, most of these participants, they said they were initially fearful of the, after effects of taking the vaccine, or were unsure about the long-term effects, but decided to get the vaccine, and for a variety of reasons, which we would enumerate later on, or have access to it. They know where the vaccination centers are, but they are delaying having the vaccine and remain indecisive if they will take it or they will not take it. And the last category was the active deniers category, where they had been offered, or they have access to it, but they have, you know uh, they do not intend to take the vaccine, have not taken the vaccine, or do not intend to take the vaccine.
So, just to summarize, even among people who accept the vaccine, there are some who do it, so to speak, hesitantly. And
Yeah.
that hesitation might manifest itself in the fact that they take maybe the first two doses but they don't take up the booster
Booster.
or something of that sort. And then you've got people who don't take it for various reasons. Um, uh, and I guess those categories cover not just the vaccine hesitant, but also the vaccine skeptical, the people who don't accept that it's that the vaccine is effective or have other beliefs about it that mean that they would refuse it. Your research covers vaccine hesitancy among ethnic minorities in the healthcare worker sector, so to speak. And one of the questions that arises is whether some of the hesitation comes from attitudes of healthcare workers to their employers.
To specifically, answer your question about trust in employers and vaccine hesitancy and how this operates. So in our research, some participants spoke of historical discrimination and racism, and how it has made people from ethnic minority communities question the entire credibility or the intention to vaccinate ethnic minority NHS staff. Um, and so, for instance, in a climate like this, so when vaccines were promoted to ethnic minority groups, so questions were raised like, if not in the past, where you had overlooked us in the past, then why is that we are becoming a priority now? So that created those kind of doubts in the minds of ethnic minority participants, I'd say. So, and these are recorded sentiments, in our qualitative data. And not just the qualitative, but also the survey research which I mentioned previously. Even our survey data, looked at these associations statistically, and found that healthcare workers who did not trust their employers were more likely to be vaccine hesitant. And if you would ask me why is it so, so particularly with the COVID vaccines, it was something new, and therefore required people to take what has been called a trust leap, or a certain amount of risk. But if you and you have to trust your employers to ensure that your well-being is ensured when you are going to take that blind leap there. And in other aspects of the interview, in the interviews that we conducted about risk perception, about guidance around, say, for instance, PPE. So there were comments like, we felt like it was the blind leading the blind. So there was these sentiments prevailing amongst our participants, where they question whether do they know actually what they are doing. So it could be that these sentiments had an impact on why lower trust in employers can lead to vaccine hesitancy. So yeah, I mean, I would see it as that, from the data, both from our qualitative as well as our quantitative work.
Just to summarize a bit of that, um, one of the issues was, as I understand you, one of the issues was that before, in the pre-vaccine stage of the pandemic, healthcare workers had not been looked after very well by their employer, because, for example, they didn't get this kind of PPE protection that they needed, the kind of wearables that acted against infection and so on. So they had been having to work in for them, dangerous conditions. So when it came to the vaccine, uh, and the healthcare workers were prioritized in getting the vaccine, so they were among the earliest to get it. Um, their thoughts about having been neglected with respect to PPE reemerged, and they wondered, are we really in good hands if the employer is asking us to take the vaccine?
Yeah, absolutely. I mean, PPE, and not just PPE, even redeployment. And I would say I would go beyond the pandemic, even before, if you see, um, the concerns of some of our participants about overlooking them for career progression, for promotions and things like that. So when you feel let down, historically, that's where this element, this breach of trust between your employer and yourself. And then when something is promoted as good, so that you tend to question the intentions, whether it's in the right intentions or whether there's something underlying there.
One of the sort of immediate reactions that many people have when they hear about vaccine hesitancy among healthcare workers, um, people express surprise that people who are probably very well informed about vaccines and other things to do with public health and infection, because they work in the health service, should be vaccine hesitancy. And that might go particularly for doctors. And there were some vaccine hesitant doctors. Um, so, what do you think explains vaccine hesitancy on the part of doctors?
That's a very good question, Tom, and I'm glad you asked this question, because there is a tendency actually about this stereotypical image of a doctor or clinician as somebody who blindly trusts science and would only follow scientific advice, and also I think during the pandemic, it further propagated about this NHS heroes, this whole narrative of heroes, that they're the saviors, they're the heroes. So I think that image is a little flawed, I would say. Uh, While I do not deny that, and definitely because of their training and because of the work experience, they are more well versed in science, I would say, than the common man. But these clinicians are also part of the same society that we are living in. They are also exposed to, I would say, the same media that we are exposed to, or getting influenced by their surroundings is very normal and natural. I would say it's human behavior. And if you see some of the concerns that clinicians were expressing, or even healthcare workers, I would say, I won't restrict myself to clinicians, about lack of long-term data, unknown side effects, which are very scientific and very relevant. You cannot just discard them as something as conspiracy or something like that. So I do not think that clinicians were swayed by opinions like they were, inserting 5G chips or something into your bloodstream through the vaccine. Those were not their concerns. Their concerns were valid about, you know, unknown side effects. And particularly in the early days when research and evidence was still very, very poor and still evolving, and there's so much of unknown. So where will they draw that scientific rationale from to make the decision? I would say, and secondly, again, vaccine decision making, what we have realized, is a very complex process. Yes, you have the scientific knowledge to assess the safety of the vaccine, but there are other factors at play too. For example, do they feel at risk? What is their perception of risk in this, or what are their friends and families telling them about the vaccine? So or later towards the vaccination program, about the efficacy against new variants. So I clearly remember this interview with she's young female, dentist, talking about, she understands the importance of vaccine, have had all her vaccines, have had her, she has one child and had a child vaccinated. But at the same time, when she heard about these concerns around the vaccine, um, causing infertility, that was something, because she is young, she is planning to have more children, and so and therefore that hesitancy to get it, because she was unsure of it. And that's very rational. It's not just the COVID vaccine. If you look at the rates of uptake of the flu vaccine, um, um, among doctors, it's still below, I think, 80%. So as I said, it's a complex decision making process, and I guess that assuming that they are healthcare workers and therefore they would be willing to readily take the vaccine would be erroneous.
I think one of the things that you've mentioned in your answer is that, in a certain sense, there's nothing special about doctors. They're members of community just like anyone else, open to influences just like anyone else. Um, but I wonder. I think that that's the nub of the issue, really. Um, whether they are like everyone else because they have specialist knowledge that's not like everyone else has. So we could distinguish between two different kinds of scientifically based hesitancy. For example, there's hesitancy that's connected with new variants, where there's an open scientific question about whether a vaccine is effective against new variants of the virus. That's a perfectly open question. Nobody disputes the cogency of that question. That's one thing. But there might be other questions about side effects. Um, it's true that side effects of COVID might not be known, but that's true of almost any medication that goes through a clinical trial. So and of course, doctors are prescribing medicines for which side effects are unknown all the time. So I mean, it's not. This is what I'm trying to. I see that there are certain senses in which scientists are not immune from the kinds of influences that everybody is open to, but there's a sense in which their scientific training ought to make them more discriminating. Uh, and I think you're saying yes, they are discriminating, more discriminating. They don't give in to conspiracy theories, but they are open to other sources of skepticism. Um, it still seems, from the point of view of the project, that as we say, certain people ought to have beliefs that are different from others just because of a scientific training. What do you think?
What I am saying is that if you're talking about scientific rationale and scientific knowledge of doctors, so what when you talk about COVID vaccine hesitancy, it's you know that's what I'm saying. What will they base their decision making on when there's not enough information? And if you see any other vaccine, it normally takes at least 5 years to go through the whole clinical process. And mind you, they are the doctors or clinicians, not everybody would be very well versed with the whole clinical trial process. So they might be just practicing clinicians
Yeah,
who
yeah, yeah.
not necessarily know the process. So yeah, those are things which can build in that hesitancy amongst doctors or even clinicians as well. So
I mean, I think what we're talking about is that there's a certain sort of social scientific take on medical people, whereas you're inclined to say some of the same social influences that affect everybody affect these people in particular. Why should they be insulated? I think that comes over clearly from what you've been saying before, and I think the standpoint that we have as philosophers is a little different. That of course, doctors are members of society. There are plenty of doctors who are irrational in some of the things they do. But if they take their training seriously, that, so to speak, speaks through them. There's a kind of a body of knowledge that's operating despite their individual peculiarities, as it were. I think that's where we're coming from. But maybe it turns out that that's not so much the case. Let's pursue the thing that we're talking about, though, because you distinguish between clinicians and, of course, ancillary workers, and so on. If you had to distinguish these two occupational groups with respect to vaccine hesitancy, what would you say?
I think in our results uh, we say that half of those who have passively accepted or actively denied were from allied health or ancillary professions. So I think there's a caveat to this. Yes, it is a descriptive result, I would say, but at the same time, this is a qualitative study. So I would not draw very strong associations between from our study. What I'm saying is between vaccine hesitancy and different professional groups. I would say I think it would be, as a qualitative from the qualitative standpoint, it would be kind of erroneous to say that one group was more hesitant than the other group, and we cannot prove it with any statistical significance. But yes, it could be a chance that most of our participants who were hesitant were from these professions. But even if I think most of the research on vaccine hesitancy amongst healthcare workers has shown that nurses or people in the nursing profession have been found to be most hesitant. And I'm just making an educated guess of this, as I said, say Tom. It could be that the difference in profession could be that one I could think of is probably around gender. So I think the NHS is a massively feminized workforce, I think, and more than 85% of the nurses are female. More than 75% of scientific or therapeutics or technical staff are female. Even so these are statistics that I'm quoting from the NHS website itself, and about 62% of managers are female. So one link I can draw between this is that this concerns around fertility, around pregnancy, around breastfeeding women, whether to take the vaccine or not, could have shown in these variations across the different roles, I would say. But as I said, that's an educated guess I'm making rather than speaking from the data itself.
No, that's very interesting. So you're basically saying that in certain cases, professional classifications, so to speak, are perhaps even disguising um, other operative forces like gender. So the vaccine hesitancy of ancillary workers, um, it may be that you have to divide through by the gender of ancillary workers to see what might be going on. I think that's very illuminating.
What I'm trying to say is that there are these intersectional factors, as you say, that it's, oh, sorry, ethnicity. So it could be a combination of all three, for somebody to be hesitant. So we have to kind of look at, or our research needs to be more informed to look at all these intersectional factors which are driving hesitancy, not necessarily just ethnicity or gender or role. So it kind of needs to be looked at in tandem, I would say.
We're getting close to the end now, and I wanted to ask you um, about one of the vignettes that you report. One of your interviewees was convinced to accept vaccination because a family member worked on the clinical trials. It seems that in this case, trust in the family member played a big role in their acceptance. What do you think of cases like these? Do you think these cases are more typical than people suppose?
I won't say it's more typical, but what we have understood from our data is that it's a two-way process. So it's not just the families of healthcare workers influencing the healthcare workers about their decisions, but it's the other way around as well. And again, as I said, it's a complex process, so you can have that influence, but how will you prioritize that, even if that influence is there? But if you feel that you are at a high risk group, or your risk of exposure is too great, you might overlook that social pressure, I would say, and go ahead and take the vaccine. Just giving an example, another interview that I can think of, this person from a certain faith, and he's a migrant in the UK, and there, lot of pressure from his family members abroad as to not take the vaccine because the vaccine contains, something which is against their faith. But this person, he rationalized that, I have a duty of care for my patients. I know that if, I have a family here, family back there, and if I get seriously ill, what's going to happen to them? So those are considerations which might, then overtake the social influence that we are talking here about. So again, I just like to reiterate that it's a complex decision making process, and I think we need more kind of research into this as to how these decisions are made and how people prioritize to take or not to take the vaccine. But it's not just one factor playing a role here. There are several factors included.
That brings me to naturally to the last question that I had here, which is, can you identify some research questions on the basis of what you've done so far that you think now require research?
In relation to vaccines, again, I'm quite interested, and that's me individually, as a researcher, quite interested in how, you know, healthcare worker parents make the decision about vaccinating their children against COVID. So that's one thing, I would be very keen, because what we have realized is that, the uptake among children is still, suboptimal. So that's probably something that needs to be looked at. Um, and probably, there are researches ongoing that I'm not aware of, but that's something which is of interest to me. And generally, our data alludes to, a lot of mental health concerns among healthcare workers. And we, the limitation of our data is that it's a one point collected at one point in time. It's not a longitudinal data, unlike our surveys. So I think it would be good to have some kind of longitudinal qualitative study to understand, the impact of the pandemic on the mental and emotional well-being of healthcare workers. And another thing which our group has already started working on is on long COVID, and how healthcare workers who are suffering from long COVID, what impact it's having on their general physical mental health, and also, the life quality of life as a whole.
Thank you very much, Mayuri, for giving us this interview.